Muchas gracias. Ahora damos paso al doctor Christian Brander, es profesor investigador senior del programa ICREA en INVESTIGACIÓN en Badalona, y nos va a hablar también de un fenotipo de pacientes muy interesante que consiguen controlar la replicación viral durante meses, incluso años, una vez que se ha interrumpido el tratamiento, e incluso alguno de ellos tras empezar en fase aguda. La charla y su ponencia tiene por nombre Post-Treatment, Post-Intervention Controllers. Muchas gracias.
Thank you very much for the introduction. The organizers for getting me here to this beautiful place I didn't know in Spain, so I'm very grateful being here. This is going to be a very short talk because I planned it thinking I had 15 minutes including the discussion. Plus, I don't really know much about post-treatment controllers and post-intervention controllers, a little bit more. So we may have more time for discussion or for going early for a rebujito that I learned already. So I also put Bea Mote on the slide because she shared some slides with me, and she is really the one who does all the clinical work and the basic immunology work behind some of the trials they're going to show you. And really I would like to, and the other reason why it's going to be short, because the three speakers before and also in the earlier session in the morning, plus Roger Paredes have essentially already told you everything. So it's going to be really short. But I want to talk just a little bit about the 002 study, ILIX 002. Roger presented this morning. That was a therapeutic vaccine study in early treated HIV-infected individuals. It was a placebo-controlled study. That's really a plus here. So we had 30 active, 15 placebos that we vaccinated with an impossibly complicated vaccine regimen, expressing always the same HDI immunogen targeting T-cell responses. And when we look at the ATI period, just to start with, what we saw, and you have seen this already this morning, in Roger's presentation, we had a number of people that controlled in the placebo group, but a larger group in the active arm. So we go from 4 people in the placebos up to about 12 in this. And when we take out the HLA genetics, I'm going to show you there are even less. But what do we learn from this here? This is really a place where we can start looking at post-treatment and post-intervention control, because evidently the placebos are just post-treatment controllers if they control. So we can start separating out, even in these small clinical trials, post-treatment from post-intervention control. And we clearly see one thing: control is not control. And I think that's a very important point that I would maybe like to see whether we can take it into this discussion. When we talk about control in a therapeutic vaccine setting, we really mean time off ART. I think no responsible doctor would let any patient walk around with this kind of viral loads, not monitored very closely after a therapeutic vaccination. And even less so would you talk about control in post-treatment controllers with this kind of viral loads. And so I think we have different bars here, and that's going to complicate how we think or not think these populations are the same and the mechanisms behind control are the same. We are talking a much bigger allowance for the therapeutic setting and the viral loads than in the post-treatment controllers. So I think already from there we have problems comparing these two groups and the mechanisms behind. And as I mentioned, when we take out the HLA genetics of this and only focus on the people that do not already express HLA B57, B27, etc., we have a more clear picture. So we have now 1 out of 12 placebos that make it out to 24 weeks in the treatment interruption versus 8 out of 20. So we have 12% versus 40% people that make it to the end of treatment interruption. But you also see the rebound kinetics here are tremendous, and the allowance for staying off treatment were based on a consensus restart criteria that is really unhealthy. Up to 8 weeks, up to 10,000 copies per milliliter, up to not even consecutive weeks, but if you were dipping below 10,000 again, you could actually renew those 10,000. Above 100,000, you were put back on treatment. So not really a healthy intervention here, and I think we need to be very clear about this. And so what also is clear is that when you look at how many patients we lose here when we restrict to the non-beneficial HLA, we lose about 75% of the ones that made it out in the ATI interruption in the placebo group from 4 down to 3, and I think from about 12 to 8. So clearly in the post-treatment group, I think the HLA genetic has a much bigger effect than in our post-intervention control, where we actually do something. And Roger showed you a little bit the correlogram this morning. He only had the positive correlations in the group of the vaccinees, not the placebos. And clearly we did something with this vaccination, but host genetic plays in both parts, but I think especially in the post-treatment control as well. And then, of course, what were the other outcome measures here? Of course, we had to look at the reservoir. We looked at the T-cell response, of course. After all, we vaccinated for that. And what you see here is my favorite graph, really, of all the various clinical trials that Bea has been running and her team. And it shows you the amount of viral reservoir on the x-axis, and this is just total DNA. We have the breakdowns for intact and non-intact and so on. And on the y-axis, you have the magnitude of the vaccine-induced T-cell response. In blue, you have the placebos, and in red, the vaccinees. And then the filled symbols are the ones that controlled for more than 12 weeks versus the one that did not in the open symbols. And what you see is all the ones, essentially all the ones that do control here are the ones that have a very strong T-cell response and a low reservoir. And the only placebo that controlled out to 24 weeks, and again, that control in very parentheses, is the one with the second or third lowest reservoir. And so possibly that person made it out there because of a very low reservoir, whilst the other ones made it because of the T-cell response. So, and we have other individuals with low reservoir that don't make it out to the 24 weeks, clearly saying that for the intervention, yes, they benefited from a boosted immune response, and that's what mediates possibly the post-intervention control, whilst for the placebos that made it, or the one that made it, the reservoir was possibly the most determining factor, but maybe not even in those people. And this is just to show that in the active arm then, what is really correlating with time off treatment was indeed what we wanted to induce with the T-cell response. Broad granzyme B reactivity to HIV, to the insert, especially of what we have put into the vaccine. So I think from this, yes, while the reservoir alone is possibly not the driving factor, certainly not in a post-intervention study like this one, where we boosted actually the immune response, and these people made it out to 24 weeks. And this is actually very nicely reproduced also in the 003 study, and there was a paper, I think that was accepted last week, where we pooled the two studies, the 002 and the 003, and we came to a cutoff of about 900 spot-forming cells of T-cell immunity to our immunogen in both studies would allow you to have about 75% probability to make it out to the end of the treatment interruption. So a clear measure that, yes, T-cell response is going to be critical in there. But how is that all relating to elite control? And we have now heard 2-3 talks that touch on the elite controllers, on the transient, on the permanent, on the low viremic or the high viremic. And so what is that in comparison to elites to start with? And I think, again, here we cannot make a direct comparison. And the mechanisms may very well vary between the different groups. I do somewhat disagree on the discrimination of the long-term controllers and non-term controllers. The host genetic is, as you showed, very strongly overrepresented in good HLA genetics, in the ones that don't lose the control. And I think there you showed also reservoir composition and all that. I think it's a different setting than a control in a post-treatment controller with or without good HLA genetics. And I think we just need to be very careful that we don't throw everything in a pot and say, oh, HIV control, because there are different clinical situations at work in these different people. And I'm going to show you just at the end 2-3 slides that I think actually this may even happen very early in infection that determines the outcome in the long run. But in this case here, evidently we are talking in 002, we're talking about one post-intervention controller, and there are evidently larger studies like the 2 that I cite here that have collected all those placebo arms from the various trials and analyzed them individually, just also to come to a clear number of what we can expect in those clinical trials to be at the level of spontaneous control in the placebo arms. Because at the end, we need to compare our placebo arm to the vaccine arm. And of course, we don't want to have many placebo controllers because those drive up or reduce the significance of the intervention controllers. But it's different groups. It's almost useless to do that because we don't know how many people in the intervention arm, in the active the vaccine is, would have controlled without the intervention. This would be the relevant number to know. But this is evidently the placebos, and that's why we have the placebos. But again, I just think these different controls are different mechanisms behind. But you see here a little bit, in people that are being early treated, we have about 5 to 15% of this spontaneous control. And then when you look a little bit into more chronically treated individuals, that number drops dramatically. Now, we have essentially, I think, exhausted most early treated infection cohorts for clinical trials, and thinking of putting or bringing that intervention of HIV cure to the possibly more than 30 million people not treated in early infection. We, of course, also expand in these cohorts, and there we see clearly a lesser level of spontaneous post-treatment control if ART was started later. Now, you can evidently not modulate when you start the treatment, but I want to go to places now, or to a short discussion of what could we actually modulate, and could we help these people to become controllers at a higher level when we prepare them right for our interventions. But before then, just also work quickly on what happens in these interventions when we stop treatment. And clearly, a an ART stop is essentially always associated with a rebound in viremia. And some people say you even need that. You need the virus to come back to drive the T cell or whatever kind of response that we think we need to drive. At the risk maybe that you may overwhelm the system if that rebound is too high or too long. So it will be very important to define the right criteria to limit that make it clinically safe and immunologically effective, that treatment interruption. And just to show you a little bit what it could look like, how long and how far we could go up, just showing here out of the Gunz paper as well, if you have exceeded 100,000 copies, you're just going to have a poor chance of bringing it back spontaneously. At the same time, we have clearly seen in our clinical trials people that do make a peak and drive it down. Within 1 week, we test them weekly, and you find somebody with 550,000 copies. You get them in to visit, you take the blood, you send them home, because the previous week the individual was still in the trial. You do the viral load on a Friday, and then on Monday you have the result, and you need to call them up and say, you should come back in because your viral load is through the roof, we need to put you back on treatment. And the moment the patient, the participant comes back, you take another blood sample, and you have a viral load of 50,000. It almost goes against half-life of the virus, this decay kinetics, and I think we do not understand them properly to make sense of them, to understand the mechanisms behind. Is it redistribution of the virus, of cells? What is it? Is it just a load of virus being produced and then no more new infections? For what reason? So I think this is very important to better understand those dynamics. And yes, when it comes to overwhelming the system, are these just, individuals that, yes, we all need a little bit of virus. I'm not sure about that, whether we really need a little bit of virus to reactivate, or whether some subclinical replication would be plenty enough to activate our cells. And there's always a little bit there, no? So why should we have detectable viremia? And then, is it just a numbers game? So could you actually start calculating the number of specific T cells divided by your foci of potentially recrudescing virus as a reservoir size, no? So is that just, you need more responses if you have more potentially reactivating virus? The virus is anyway reactivating. It's always ready to go, no? So you just may need to have a little bit more cells if you have more foci of reactivating virus. And that made me think that in acute infection, we have people that go up to millions in viral loads, and they bring it down on their own to viral set point. We're now looking into an acute infection cohort in Peru with deferred treatment. This is done 10 years ago. But people were led off treatment, monitored monthly for viral load, and now we have natural history, essentially, to look at these people. And from your clinical past as well, where you did a viral load, had 1 million copies, but that was just not indicated to treat just yet, or it was simply not available. And people bring this down by magnitudes on their own, and even more so in the absence of a pre-existing vaccine-induced immunity. How does that work? What are the mechanisms behind this containment and achieving set point, wherever it is? It's a pseudomanga B or an LE controller, or whatever it be, But the dynamics are so that you can actually bring down the virus tremendously. And then why does this not happen in the therapeutic setting? Are we just too much exhausted, do not target the right thing, has the virus escaped, etc.? And yes, and this is not a criticism, this is just to state the fact, the current consensus on ART restart criteria does not allow us to test some of these questions, which of course scientifically is a pity, but for the safety of the patient I think is also a necessity. And then of course we are all talking about ATI, predictors of rebound and so on, but really, why would we even want to vaccinate somebody, especially with regimens that are just so abusive as this one here, if we could tell at baseline, look, you're not going to respond. There's just no way that you're going to make ever a good immune response again. Maybe that's wrong, but if we knew it, we could save people the whole ordeal. Like we should try to avoid people going into an ATI if we know it's not going to work. We should not send them into an ATI either. So what are those predictors? Can we actually identify them? At baseline, for the vaccine study, that's easy. What is baseline? Well, it's before you vaccinate the first time or in screening. What is baseline for a placebo? It's essentially any time point before you stop treatment. So it's the pre-ATI time point, essentially, that we should try to identify predictors of rebound. Or throughout the vaccination, that you can abort the mission and say, well, you didn't respond 3 times, so why should I give you 5 more vaccinations? You have an inherent problem with making a vaccine response, and this is where I would like to get to in the last 2 or 3 slides. But just to mention, but not going into, equally important, of course, is also to find the predictors of rebound in the ones that we term controllers in ATI, because if we ever should be able to bring them down to a level that is acceptable clinically, we also need to make sure we capture them before they go through the roof, because they're all living in a relationship with other people, may have been happily having unprotected intercourse, thinking, oh, I'm no longer infectious, but we need to understand the dynamics there, and I think some of this work that predictors of rebound are very, very critical to be addressed as well. And so just to finish up with 3 slides then, what are the pre-ART, the pre-ATI, pre-vaccination measures that we could employ here to make sense of therapeutic vaccination or other interventions? And one is clearly reservoir. Reservoir is clearly having an effect on the on the outcome of ATI. So to possibly we just need something that can do with LRA activity, reawaken the virus, if that's a strategy we want to optimize in the context of therapeutic vaccination. And then Roger went at length already this morning in the BCNO. So I had the BCNO2 data here. He showed the stuff for ALIX 002. It goes straight down the same line. The Bacteroides, Clostridium ratios really tell you what's going to happen. And they tell you that at beginning, before the first vaccination. So in 002, we have a predictor on the microbiota composition that tells you you're going to respond well to vaccination. And responding well to vaccination, that's why I showed you the data there, is also associated with control in ATI. So hence, microbiota is essentially directly predicting ATI outcome. And so this is an excellent thing to observe, because we can act on this possibly. If we really understand what's playing a role, whether it's arginine, whether it's bile acid, whatever it is, we can possibly mimic that. We're not going to eat caca to restore, or not even yogurt. We're going to target the mechanism that helps us to mimic this situation of somebody having a good microbiota. The one that is a little bit less modulatable possibly is epigenetics, and this is something we have been looking at for a good number of years by now, especially Marta Ruiz in the lab, and she gave a talk on epigenetics on Sunday, I think, as well. So she is really the one who has produced all this data. This is again from BCNO2, the old study with a handful, or not even a handful, of controllers that show different DNA methylation profiles across the host genome. And this, of course, this falls then into more or less interesting categories and gene ontology groups and so on. You can make all the story out of what you want. But for me, the more important part is, well, if we have pre-baseline or pre-vaccination epigenetic signatures that define how we're going to respond to vaccination, how we're going to deal with the virus once we stop treatment, then we have maybe a problem. We need to understand then how we can restore a better epigenetic profile. At least, we need to very clearly understand what genes are turned on and off, and then maybe help that. It's very easy. If you find an IL-17 gene super hypermethylated on 15 spots, well, maybe you just give a little bit of IL-17, and that could help driving that response. Or if it's hypomethylated, you may need to give an antibody against it, and then you're at the same point. You not necessarily need to go in and with epidrugs and changing every DNA methylation position. But it will give us insights, but it may tell us that there's bottlenecks and hindrance in the way to an effective vaccination. And the last two slides, I just want to show you when in infection this could happen. And for this, we took a study, the SCAR study that we have at IRSIGACHA with the group of Javier Martinez-Picado as well. This is now only 5 people that we have pre- and post-HIV infection samples and then post-treatment. This is a cohort that we started back in like 2008 with Checkpoint Barcelona, and we got about a dozen of them. And this was built on a study that I did earlier in Peru, and we also got about 10 individuals that we have pre- and post-infection. And now a bigger study done also, again, a few years back, where I mentioned we have now the natural history, was done on 200. So they identified 200 individuals that had pre-infection samples stored and then followed over the years, now still to now. And so in this study, what Marta did was just looking here at DNA methylation profiles in 4 subtypes, or 4 groups of cells: CD4 cells, CD8 T cells, B cells, and everything else, non-TB cells, whatever went through the flow cytometer on the other end. And what you see, and then just comparing here, the T1 to T2 is pre to post-infection, and T2 to T3 is post-infection to post-treatment. And what you see, for instance, for the CD or for the B cells, you see a strong activation here, upregulation of a whole bunch of signatures once you're infected. and then going down regulation of this or loss of these methylation profiles again once you're back on treatment. And you see this very marked for CD8 cells as well, for CD4 less so. And when you look a little bit into the gene ontology of this, and sorry, this is awfully out of that was not the intention, because I wanted to show you that really for the CD4 cells, for instance, on the left side there, you have the same gene ontology pathways methylated after infection that you have them after treatment, 1 year after treatment. So the CD4 dysregulation, epigenetic dysregulation is not restored after after 1 year on treatment. On the other side, CD8 cells, the top 3 categories are all the ones that are upregulated and downregulated. So hypermethylated or then or hypomethylated, and then afterwards they revert back to be hypermethylated and silenced again. So that seems to me to tell that the CD4 cells suffer a permanent damage. This is the total population. This is not HIV-infected cells. This is your entire environment. Seem to last on beyond treatment, whilst the CD8 epigenetic profiles are being restored, and the B cells similarly as well. And this is just to conclude. I think all these different control groups are very different. We need to be very careful what we can conclude and how we can compare them. In all of the cases, it's possibly more than just one single factor that we need to identify, and we need to bring that into treatment strategies for cure that can be really modulate, and the epigenetic is just one of them that may need to have a little bit more work done. And I just want to point out everybody at IRSIGACIA, especially Bea and Marta, with Javier and Roger, to have been in the audience, are still in the audience, and everybody else who helped us with these studies. Thank you very much.